Good evening, Dr. Phil here. Today we'll be discussing on beta blockers. Introduction. Beta blockers act by beta-adrenergic receptor blockade. They are also class 2 antiarrhythmics based on the Vaughan-Williams classification. Beta-adrenoreceptors. These are G-protein coupled receptors activated by adrenaline or other catecholamines. Effects are mediated by second messengers. Beta receptor effects by increasing cAMP via GS-coupled adenylate cyclase activation. Role of beta-1 receptors in the heart, positive inotropic and chronotropic effects, and coronary vasodilation. In the juxtaglomerular apparatus, increase renin secretion. In the adipose tissue, lipolysis. Roles of beta-2 adrenoreceptors in the CVS, increased automaticity of the heart, coronary vasodilation, vasodilation of arterioles and veins. In the lungs, reduced secretions and bronchodilation. In the liver, glycogenolysis and gluconeogenesis. In the GI tract, watery secretion for salivary glands, reduced motility and sphincter constriction. In the pancreas, increased insulin and glucagon secretion, bladder relaxation, uterine relaxation, inhibition of platelet aggregation, lipolysis in adipose tissue, and relaxation of ciliary muscles. Role of beta-3 adrenoreceptors, lipolysis and thermogenesis in adipose tissue. Indications for beta blockers: in the treatment of hypertension, in the treatment of ischemic heart disease to improve symptoms and decrease the frequency and severity of silent myocardial ischemia, for secondary prevention of arrhythmias and further infarction after myocardial infarction. Early IV administration after acute MI can reduce infarct size, incidence of ventricular and supraventricular arrhythmias, and reduce mortality in both lower and higher risk groups. If oral therapy is continued for 2 to 3 years, there is reduced risk of reinfarction. In congestive heart failure, beta blockers improve outcome in cardiac failure when added to ACE inhibitors. Bisoprolol, Metoprolol, and Carvedilol decrease morbidity and mortality in heart failure by improving ventricular function and upregulation of beta receptor density or function, slowing of heart rate, antiarrhythmic effects, and antioxidant effects. Beta blockers must be introduced cautiously in heart failure because symptoms may initially worsen, and ventricular function improves only after 1 month of therapy. Avoid beta blockers in patients with poor ventricular function for fear of precipitating cardiac failure. Beta blockers are used in the prevention of sympathetic-induced tachyarrhythmias provoked by endogenous or exogenous catecholamines, emotions, or exercise, such as SVT, AF, and sinus tachycardia. Beta blockers are used in rate control in AF, such as Esmolol and Metoprolol achieve successful rate control in 70% of cases of acute AF. Beta blockers are preferred for rate control in AF in hyperadrenergic states. However, they are contraindicated in decompensated systolic heart failure. In hypertrophic obstructive cardiomyopathy, beta blockers improve exercise tolerance and alleviate symptoms by reducing heart rate, myocardial work, contractility, outflow tract obstruction, and control of infundibular spasm. However, incidence of sudden death in this condition is not affected. Cyanotic episodes caused by pulmonary outflow obstruction in patients with Fallot's tetralogy is reduced by a similar mechanism. Propanolol is used in the treatment of hyperthyroidism. Anxiety states may be treated with beta blockers. Topically applied beta blockers are used in the chronic management of glaucoma, such as Timolol, Bedaxolol, or Cartiolol. Beta blockers reduce intraocular pressure in glaucoma by reducing the secretion of aqueous humor by the ciliary body. Unlike cholinergic drugs, beta blockers do not affect the ability of the eye to focus for near vision nor change pupil size. Onset of action is 30 minutes with a duration of action of 12 to 24 hours. Significant systemic absorption may still take place, Bradycardia, hypotension, and bronchospasm may occur, particularly during anesthesia. Acute attacks of glaucoma is treated with pilocarpine, a topical cholinergic agonist. Beta blockers are used in treatment of isoproterenol overdose, which is a beta-1 and beta-2 agonist. In the presence of a beta blocker, isoproterenol does not produce cardiac stimulation, which is beta-1 mediated, or reductions in mean arterial pressure and diastolic pressure, which is beta-2 mediated. Beta blockers prevent reflex tachycardia associated with alpha blockade in the treatment of pheochromocytoma. Beta blockers are used in the prophylaxis of migraine. Contraindications for beta blockers includes cardiogenic shock, severe bradycardia, second or third degree heart block, sick sinus syndrome, uncontrolled cardiac failure, hypotension, asthma, allergy, etc. Mechanism of action. Effects of catecholamines are antagonized by beta blockers. Beta blockers are structurally similar to beta agonists, but do not activate adenylate cyclase and the second messenger system, despite binding avidly to the beta adrenergic receptor. Most are stereoisomers, and the L form is generally more potent. Beta blockers are competitive antagonists with high receptor affinity, although their effects are attenuated by high concentrations of endogenous or exogenous agonists. Beta blockers binding to beta adrenergic receptor is reversible, such that the drug can be displaced from the occupied receptors if sufficiently large amounts of agonists become available. Increased number of beta adrenoreceptors may occur when beta blockers are administered over a prolonged period. Adverse effects such as tachycardia, hypertension, and myocardial ischemia may occur upon abrupt withdrawal of beta blockers. Beta blockers have different pharmacodynamic profiles due to differences in beta-1 receptor selectivity, intrinsic sympathomimetic activity, membrane stabilizing activity, ancillary effects, and inter-patient variability. Regarding beta-1 receptor selectivity, Atenolol, Esmolol, Metoprolol, Practolol, Betaxolol, Bisoprolol, Nebivolol, and Acebutolol demonstrates beta-1 adrenoreceptor selectivity or cardioselectivity. When given in high dose, beta-2 antagonism may also be seen. Selectivity of both drugs and tissues is only relative. All beta-1 selective drugs antagonize beta-2 receptors at higher doses, and 25% of cardiac beta receptors are the beta-2 subtype. In general, beta blockers' antagonism of beta-1 receptors results in useful effects, and antagonism of beta-2 receptors results in unwanted effects. Beta-1 selective drugs appear to have fewer adverse effects on blood glucose control in diabetics. They have less effects on serum lipids and less effects on the bronchial tone in patients with chronic obstructive pulmonary disease. All beta blockers may precipitate cardiac failure in patients with poor ventricular function. Intrinsic sympathomimetic activity. Some beta blockers have partial agonism such as Pindolol, Acebutolol, Celiprolol, and Propanolol. Beta blockers with partial agonist activity produce sympathomimetic effects when circulating levels of catecholamines are low. They produce antagonist effects when sympathetic tone is high. They stimulate beta receptors to which they are bound, but inhibit stimulation by more potent endogenous catecholamines such as adrenaline and noradrenaline. These opposing actions produces a diminished effect on cardiac rate and cardiac output compared to that of beta blockers without intrinsic sympathomimetic activity. They are less likely to induce bradycardia and heart failure in patients with mild cardiac failure. They may be advantageous in patients with a low resting heart rate because they reduce the risk of AV conduction disturbance. They should not be used in patients with severe cardiac failure as beta blockade reduces cardiac output. These drugs has minimal disturbances of lipid and carbohydrate metabolism, unlike other beta blockers. For example, these agents do not decrease plasma HDL levels. Some beta blockers such as Celiprolol, Carvedilol, and Acebutolol has membrane stabilizing activity. and inhibit sodium transport in nerve and cardiac conducting tissue. However, this has little clinical significance as doses required to elicit them are higher than those seen in vivo. Some beta blockers have ancillary effects such as alpha-1 adrenoreceptor blockade. Labetalol and Carvedilol are antagonists at alpha-1 adrenergic receptors. Unlike other beta blockers that produce initial peripheral vasoconstriction, these agents produce peripheral vasodilation. They are useful in treating hypertensive patients for whom increased peripheral vascular resistance is undesirable. Potassium channel blockade. Sotalol is a beta blocker that has class 3 activity by blocking potassium channels, and this prolongs repolarization in the heart. Vasodilation. Celiprolol produces vasodilation by a mechanism involving endothelial nitric oxide. Bucindolol produces direct vasodilation by a cAMP-dependent mechanism. Antioxidant effects. Carvedilol has antioxidant effects and it reduces lipid peroxidation and vascular wall thickening, which is beneficial in heart failure. Interpatient variability. Therapeutic plasma concentrations vary greatly among beta blockers and between patients. Explanations for interpatient variability and differences in individual plasma concentration response relationships include differences in basal sympathetic nervous system tone, genetic differences in beta-adrenergic receptors that influence how an individual patient responds to a given drug and plasma concentration, effects of active metabolites, and flat dose response curves for the drugs, so changes in plasma concentrations evoke minimal changes in pharmacologic effects. Pharmacodynamics. Cardiac effects. Beta blockers produce negative chronotropy and inotropy on cardiac muscle. They reduce automaticity in SA node and AV node and ectopic pacemakers and prolongs phase 4 depolarization, producing bradycardia. They increase the refractory period of the AV node and prolongs AV node conduction. Negative inotropic effects reduces myocardial contractility. This may be disadvantageous in patients with acute left ventricular dysfunction and may lead to cardiac failure. Beta blockers produces improvements in the balance of myocardial oxygen supply and demand. Oxygen demand of the heart is reduced by reduction in contractility and reduced exercise-induced increases in arterial pressure, velocity of cardiac contraction, and oxygen consumption at any workload. Oxygen supply to the heart is increased by bradycardia, which produces lengthening of the coronary artery perfusion time during diastole. These effects are more important than those that tend to compromise the supply-demand equation, such as increased systolic ejection time, dilation of ventricles, and antagonism of the vasodilatory beta-2 coronary receptors, which increases coronary vascular resistance. As beta blockers reduces oxygen demand and increases oxygen supply to the heart, this forms the basis for the use of beta blockers in angina and perimyocardial infarction. Antiarrhythmic activity of beta blockers. Beta blockers are class 2 antiarrhythmic drugs. They are mainly used to treat arrhythmias associated with high levels of catecholamines. Some beta blockers have class 1 activity at high doses, but this has little clinical significance. Sotalol has class 3 activity. Summary of the cardioprotective effects of beta blockers includes reduced myocardial oxygen consumption and demand, increased coronary blood flow owing to increased diastolic time, redistribution of coronary blood flow to ischemic areas, reduced stress on potentially ischemic myocardium owing to reduced heart rate and myocardial contractility, attenuation of effects of endogenous catecholamines. Beta blockers reduces the effects of noradrenaline on cardiac muscle fibers, which includes remodeling, hypertrophy, and cell death. Cardiac antiarrhythmic effects, plaque stabilization owing to reduced shear forces, and anti-inflammatory effects. All beta blockers are equally effective as hypotensive drugs. Patients unresponsive to one beta blocker are generally unresponsive to all. Mechanism by which beta blockers control blood pressure is not yet fully understood. Actions that reduce blood pressure includes reduced heart rate, reduced myocardial contractility, reduced cardiac output, inhibition of the renin-angiotensin system, inhibition of beta-1 receptors at the juxtaglomerular apparatus reduces renin release and angiotensin II and its effects. Baroreceptors may be set at a lower level. Presynaptic beta-2 receptor blockade may inhibit noradrenaline release. Beta blockers may reduce central sympathetic activity. However, the significance of this is uncertain, as different drugs vary widely in CNS penetration. Actions that increase blood pressure includes antagonism of peripheral beta-2 receptors plus unopposed alpha stimulation produces vasoconstriction. This produces little hypertensive effect, but may result in poor peripheral circulation and cold hands. Beta blockers do not induce postural hypotension, as alpha adrenoreceptors remain fully functional. Some beta blockers have intrinsic sympathomimetic activity, such as Pindolol, Acebutolol, Celiprolol, and Oxprenolol, which may increase blood pressure. Respiratory effects includes bronchospasm via beta-2 antagonism. Metabolic effects. Beta blockade reduces glycogenolysis and glucagon secretion, and this may reduce blood sugar. Non-selective beta blockade may obtund the normal blood sugar response to exercise and hypoglycemia, and may mask the normal symptoms of hypoglycemia. Beta blockers should not be used with hypoglycemic agents. Non-selective beta blockade may increase the resting blood sugar levels in diabetics with hypertension. Beta blockers may increase triglyceride levels and reduce high-density lipoproteins. CNS effects. Lipid-soluble beta blockers such as Metoprolol and Propanolol may produce CNS effects such as depression, hallucination, nightmares, paranoia, and fatigue. Ocular effects. Beta blockers reduces production of aqueous humor, and this reduces intraocular pressure. The GI tract. Beta blockers may produce dry mouth and GI disturbances. Pharmacokinetics. All beta blockers are weak bases. Protein binding is variable. All beta blockers are distributed widely throughout the body. Significant concentrations occur in the CNS, particularly for more lipid-soluble drugs. Lipid solubility. Beta blockers with low lipid solubility, such as Atenolol, Sotalol, Propanolol, Celiprolol, and Nebivolol, have characteristics such as poor absorption from the gut, reduced hepatic metabolism, and they are excreted largely unchanged in the urine. Beta blockers with high lipid solubility, such as Esmolol, Metoprolol, Oxprenolol, Propanolol, Atenolol, Labetalol, Acebutolol, and Pindolol, have several characteristics such as good absorption from the gut, extensive metabolism in the liver with marked first-pass effect and low oral bioavailability, shorter half-life requiring more frequent administration, and crossing of the blood-brain barrier which produces CNS effects. Half-lives: less than 10 minutes, Esmolol, 2 to 4 hours, Metoprolol, Oxprenolol, Pindolol, Propanolol, and Atenolol, 6 to 12 hours, Atenolol, Propanolol, and Sotalol, 24 hours, Nebivolol. General adverse effects of beta blockers includes bradycardia. Beta blockers prevent the compensatory tachycardia which accompanies hypovolemia, so that severe hypotension may occur if intravascular replacement is delayed. Beta blocker-induced bradycardia may be treated with atropine, beta agonist, glucagon, calcium chloride, or cardiac pacing. Beta blockers can cause hypotension. They can also cause cardiac failure, especially in combination with other negative inotropes. They may precipitate heart failure in patients with poor LV function and should not be given to patients with an acute exacerbation of heart failure. However, Carvedilol, Metoprolol, and Bisoprolol are beneficial in patients with stable chronic heart failure. These drugs work by blocking the effects of sympathetic stimulation on the heart, which causes worsening of heart failure over time. Evidence demonstrates improved systolic functioning and reversed cardiac remodeling in patients receiving beta blockers. There may be occasional initial exacerbation of heart failure symptoms, and treatment should be started at low doses and gradually titrated to target doses based on patient tolerance and vital signs. Peripheral arterial insufficiency may occur via blockade of beta-2 receptors. Bronchospasm may occur in patients with asthma or chronic bronchitis who rely on sympathetically beta-2 mediated bronchodilation. Beta-1 selective drugs are theoretically less likely to aggravate bronchospasm in asthmatics, but because their selectivity is only relative, they should not be considered completely safe. Beta blockers increases the risk of diabetes when used to treat hypertension. They may also reduce the response to hypoglycemia in diabetics by reducing cardiovascular response via beta-1 blockade and metabolic response via beta-2 blockade, which reduces glycogenolysis. CNS effects includes nightmares, hallucinations, insomnia, and depression, and are more common with lipophilic beta blockers such as Propanolol, Acebutolol, Oxprenolol, and Metoprolol, and is less likely with water-soluble beta blockers. Muscle fatigue may possibly occur from blockade of beta-2 mediated vasodilation in muscles during exercise. Nausea, vomiting, and diarrhea are idiosyncratic reactions of beta blockers. Impotence may occur. Withdrawal phenomenon may occur after abrupt cessation of long-term beta blockade for angina. It may present with rebound tachycardia, worsened angina, or precipitation of myocardial infarction. Drug-specific adverse effects, such as torsade de pointes for Sotalol and oculomucocutaneous syndrome by Practolol, kindly refer to the respective beta blockers for further details. Fetal effects. Beta blockers can cross the placenta and cause bradycardia, hypotension, and hypoglycemia in newborn infants of mothers who are receiving the drug. Beta-adrenergic receptor antagonist poisoning is uncommon. Overdose is hazardous because these drugs have low therapeutic ratios. Features include cardiac failure, bradycardia, cardiac conduction defects, hypotension, bronchospasm, coma, convulsions, ventricular tachyarrhythmias with Sotalol, and hypoglycemia. Treatment is as for poisoning and overdoses in general. Discontinue the beta blocker. CVS effects may require CPR. Useful drugs to treat beta blocker overdose includes beta agonists such as dobutamine or isoprenaline, glucagon IV 2 to 20 mg or IV 50 to 150 micrograms per kg in children, followed by IVI 50 micrograms per kg per hour. Atropine is often ineffective but should be tried in vagal blocking doses such as 3 mg IV in adults and 40 micrograms per kg in children. Other options include calcium chloride and cardiac pacing. Beta blockers and anesthesia. Specific perioperative indications for beta blockade includes prevention or treatment of intraoperative hypertension, tachycardia, and SVT associated with excessive sympathetic activity, for example to suppress the response to laryngoscopy and at extubation using Esmolol. Treatment of postoperative hypertension, controlled hypotension, i.e. hypotensive anesthesia, prophylaxis or treatment of perioperative myocardial ischemia, pre- and perioperative management of pheochromocytoma, pre- and perioperative management of thyrotoxic patients. Interactions of beta blockers with anesthetic agents. Negative inotropic effects of beta blockers are additive with anesthetic agents and may cause exaggerated hypotension. Beta blockers may mask compensatory tachycardia. Caution with concomitant use of any cardiovascular depressant drugs with beta blockers. Acute withdrawal of beta blockers may result in angina, ventricular extrasystoles, or even precipitate myocardial infarction. Use of perioperative beta blockade to reduce perioperative cardiovascular morbidity and mortality in high-risk patients undergoing non-cardiac surgery is no longer advocated. The cardiovascular benefits are outweighed by increased cerebrovascular accidents. There are controversies surrounding the perioperative use of beta blockers following the POISE trial. The latest recommendations suggest that patients already taking beta blockers should remain on them, as abrupt withdrawal of beta blockers may result in several adverse effects. Patients receiving long-term beta blockade should continue therapy throughout the perioperative period. Patients undergoing high-risk surgery who have evidence of inducible ischemia, coronary artery disease, or multiple risk factors for coronary artery disease should start low-dose beta blocker treatment at least 1 week preoperatively. For all other patients, the use of beta blockers cannot be recommended. Beta blocker therapy should not be started on the day of surgery. Beta blockers with high lipid solubility. Propanolol. Propanolol is a racemic non-selective beta blocker without intrinsic sympathomimetic activity. The S isomer confers most of its beta blocker effects, and the R isomer is responsible for preventing the peripheral conversion of T4 to T3. Propanolol is used in the treatment of hypertension, angina pectoris, portal hypertension, thyrotoxicosis. Propanolol inhibits the effects of thyroid hormones and prevents the peripheral conversion of T4 to T3. Propanolol is also used to treat essential tremor, pheochromocytoma, and in the prophylaxis of migraine. Oral doses ranges from 160 mg to 320 mg daily. The dose for treatment of hypertension, portal hypertension, angina, migraine, and pheochromocytoma is 30 to 80 mg orally BD, increased up to 120 to 320 mg per day. The dose for treatment of arrhythmias, hypertrophic obstructive cardiomyopathy, anxiety, and thyrotoxicosis is 10 to 40 mg orally BD or TDS. Higher doses may be required in thyrotoxicosis due to increased clearance. The dose to treat acute coronary syndromes is 40 mg orally QDS for 2 to 3 days, then 80 to 160 mg per day. The dose for acute IV administration is 1 mg over 1 minute, repeated as required, up to 5 to 10 mg. The onset for beta blockade via IV route is 2 to 10 minutes, via oral route is 1 to 2 hours. The onset for reducing hypertension via oral route is 2 to 3 weeks. Duration of action is 6 to 12 hours for immediate release and 24 to 27 hours for extended release. Pharmacokinetics of propanolol. Lipid solubility is high. GI absorption is 90%. Peak plasma time is 1 to 4 hours for immediate release and 6 to 14 hours for extended release. Bioavailability is 30%. Protein binding is 90%. This may be reduced by heparin. Elimination half-life is 4 hours. However, actions appear to persist for longer than 4 hours. Metabolism is hepatic. Hepatic metabolism of the R isomer is more rapid than the S isomer. Elimination is dependent on hepatic metabolism but is impaired in renal failure by an unknown mechanism. Active metabolites includes 4-hydroxypropanolol, which has beta-blocking activity. 96 to 99% is excreted in the urine. Adverse effects are as for beta blockers. Propanolol decreases both the clearance of amide local anesthetics by decreasing hepatic blood flow and inhibiting metabolism, and the pulmonary first-pass uptake of fentanyl. Labetalol. Labetalol is used to treat hypertension, especially when there is tachycardia, hypertensive crisis, pregnancy-induced hypertension, and preeclampsia. Labetalol is an alternative to metal-dopa in the treatment of PIH. Labetalol is also used in the treatment of pheochromocytoma and used in hypotensive anesthesia. Presentation includes 50 to 400 mg tablets or a colorless solution containing 5 mg per ml. Dose of labetalol for IV boluses 5 to 20 mg over 2 minutes, titrated up to a maximum of 300 mg in 24 hours. Maximum effect usually occurs within 5 minutes. Duration of action is usually 6 hours. Intravenous labetalol in small increments, such as 5 to 10 mg, produces a controlled decrease in arterial pressure over 5 to 10 minutes with no change in cardiac output or reflex tachycardia, suggesting that at this dose the vasodilating action predominates. Negative inotropic and chronotropic effects occur at higher doses as the beta blocking effect becomes more prominent. The dose for infusion is 20 to 200 mg per hour. Labetalol is incompatible with sodium bicarbonate. The oral dose is 100 to 800 mg BD and may be increased to a maximum of 2.4 grams daily. Mechanism of action. Labetalol is a competitive alpha-1, beta-1, and beta-2 antagonist and a partial agonist at beta-2 receptors. Labetalol contains two asymmetric centers and exists as a mixture of four stereoisomers present in equal proportions. The SR stereoisomer probably confers alpha-1 blockade, and the RR stereoisomer probably confers beta blockade. The ratio of alpha-1 to beta blocking effects for oral route is 1 to 3 and IV route is 1 to 7. Selective alpha-1 blockade produces peripheral vasodilation. Non-specific beta blockade prevents reflex tachycardia and reduces myocardial afterload and oxygen demand, which is favorable for those with angina. Pharmacokinetics. Labetalol has high lipid solubility, GI absorption is 70%, bioavailability is 25%, protein binding is 50%, metabolism is hepatic, reduced dose in hepatic failure. There are no active metabolites. Excretion is via urine and feces. Elimination half-life is 5 hours. Adverse effects are as for beta blockers. There are rare reports of severe hepatocellular damage, which is usually reversible. Labetalol may cause false positive tests for pheochromocytoma due to labetalol metabolites in urine. Esmolol. Esmolol is a highly lipophilic, relatively cardioselective beta blocker with a rapid onset and offset. It has no intrinsic sympathomimetic activity or membrane stabilizing properties. Esmolol is used in the short-term management of tachycardia and hypertension in the perioperative period, for example, associated with tracheal intubation. It is used in the treatment of acute SVT, sinus tachycardia, and in hypotensive anesthesia. Contraindications are as for beta blockers. Esmolol is not compatible with sodium bicarbonate. It is only available intravenously as a clear liquid, either 2.5 grams or 100 mg in 10 ml. The former should be diluted prior to administration to 10 mg per ml. The dose for SVT is 500 micrograms per kg per minute loading dose IV for 1 minute, followed by 50 to 150 micrograms per kg per minute maintenance titrated to effect. The dose for perioperative use is 0.5 to 1 mg per kg IV over 15 to 30 seconds, followed by 50 to 300 micrograms per kg per minute infusion. Onset time is 1 to 2 minutes. Pharmacokinetics. Esmolol is highly lipid-soluble with a VD of 3.5 liters per kg. Protein binding is 60%. It is rapidly metabolized by red blood cell esterases to inactive acid metabolite and methyl alcohol. Esterases responsible for its hydrolysis are different from plasma cholinesterase so that it does not prolong the actions of succinylmetonium. Elimination half-life for the parent drug is 9 minutes. For the acid metabolite is 3.7 hours. Clearance is via plasma hydrolysis. There are no active metabolites. Excretion is mainly via urine. Adverse effects are as for beta blockers. Esmolol is irritant to veins and may cause pain on injection, and extravasation may lead to tissue necrosis. Its short duration of action limits the duration of its adverse effects. Metoprolol. This is a relatively cardioselective beta blocker with no intrinsic sympathomimetic activity. At higher doses, it also inhibits beta-2 adrenoreceptors. It is used in the treatment of myocardial infarction. Early use of metoprolol reduces infarct size and the incidence of VF. It is also used in the treatment of angina pectoris, tachyarrhythmias, thyrotoxicosis, and hypertension. Cardioselective beta blockers are useful in hypertensive patients with impaired pulmonary function and are also first-line therapy for chronic stable angina. Metoprolol is also used in migraine prophylaxis. Oral dose is 50 to 200 mg daily. A typical regime would be 25 to 50 mg, 8 to 12 hourly. The IV dose is up to 5 mg for arrhythmias and in MI, and can be repeated at 5-minute intervals until a satisfactory response occurs. A total dose of 10 to 15 mg generally proves sufficient. Equivalent maximal beta blocking effect is achieved with oral and IV doses in the ratio of approximately 2.5 to 1. The onset time via the IV route is 20 minutes, but the onset may be immediate depending on clinical setting. The onset time for oral route is 1 to 2 hours. Duration of action for IV route is 5 to 8 hours. For oral route is dose related and is typically 3 to 6 hours, but may be up to 24 hours for extended release formulas. Pharmacokinetics of Metoprolol. It is highly lipid soluble, thus it crosses the blood-brain barrier, enters breast milk, and has high GI absorption of 95%. Peak plasma time for immediate release is 1.5 to 2 hours and 3.3 hours for extended release oral formulation. Bioavailability is 50% and increases to 70% during continuous administration or when given with food. Protein binding is 20%, elimination half-life is 3 to 7 hours, genetic polymorphism affects hepatic metabolism, producing two different half-life profiles of 3 and 7 hours. Elimination half-life is subject to enzyme inducers and inhibitors. Metabolism is in the liver, reduced dose in hepatic failure. There are no active metabolites. Excretion is via the urine. No dose reduction is required in patients with renal failure. Adverse effects are as for beta blockers. Acebutolol. It is used in the treatment of hypertension, ventricular arrhythmias, and angina pectoris. It is only available orally at a dose of 400 mg BD, but may be increased to 1.2 grams per day if required. Effects. It is a relatively cardioselective beta blocker with limited intrinsic sympathomimetic activity and some membrane stabilizing properties. Onset time is 1.5 to 3 hours for the initial response and 3 to 8 hours for the peak response. Duration of action is 12 to 24 hours. Pharmacokinetics. Acebutolol has high lipid solubility but does not cross the blood-brain barrier to any great extent. GI absorption is 90%. Peak plasma time is 2 to 3 hours. Bioavailability is 40%. Protein binding 25%. Elimination half-life for acebutolol is 3 to 4 hours. For its active metabolite diacetolol, it is 8 to 13 hours. Metabolism is in the liver. Active metabolite is diacetolol, which is less cardioselective than acebutolol. Excretion is via the urine 30 to 40%, bile 3 to 8%, and feces 56%. There is enterohepatic recycling. Dose should be reduced in the presence of renal impairment. Adverse effects are as for beta blockers. Carvedilol. It is used in the treatment of congestive heart failure, hypertension, left ventricular dysfunction following MI, and angina pectoris. Presentation includes oral capsules or tablets. Effects. It is a stereoisomer and antagonist at alpha-1 and beta receptors with a relative beta to alpha-1 selectivity of 10 to 1. Carvedilol has antioxidant activity and inhibits endothelin synthesis. It may have calcium channel blocking effects at higher doses and membrane stabilizing effects. Carvedilol does not have beta-1 selectivity or partial agonist activity. Onset of action occurs in 1 hour. Duration of action is 24 hours. Pharmacokinetics. Carvedilol is highly lipid soluble. Absorption via the GI route is more than 90%. Bioavailability is 25%. Protein binding is 98%. Elimination half-life 6 to 10 hours. Metabolism is in the liver. Carvedilol is contraindicated in severe liver impairment. Inhibitors of CYP2D6, CYP2C9, and other hepatic cytochrome enzymes may increase the levels of carvedilol and increases the risk of adverse effects. The 4-hydroxyphenyl metabolite is active and approximately 13 times more potent than carvedilol for beta blockade. 60% is excreted in the feces and 16% in the urine. No dose adjustments are necessary for renal failure. Adverse effects are as for beta blockers. Carvedilol is a substrate for P-glycoprotein. Carvedilol's effects may increase if it is co-administered with P-glycoprotein inhibitors. Nebivolol. It is used in the treatment of hypertension and available as oral tablets. Dose adjustments are required for hepatic or renal impairment. Effects. It is a lipophilic beta-1 selective blocker, which is administered as a racemic mixture of equal proportions of D and L enantiomers. Blockade of beta-1 adrenergic receptors leads to reduced heart rate, reduced myocardial contractility, and reduced blood pressure. Nebivolol has vasodilatory effects mediated by endothelial nitric oxide. L-nebivolol is responsible for beta-3 adrenergic receptor agonist activity that stimulates endothelial nitric oxide synthase. This increases nitric oxide levels, vasodilation, reduced peripheral vascular resistance, increased stroke volume, ejection fraction, and cardiac output. Onset time is 1.5 to 4 hours, duration of action 48 hours. Pharmacokinetics. Nebivolol is highly lipid-soluble with good GI absorption. Bioavailability ranges from 12 to 96% for extensive to poor CYP2D6 metabolizers. Protein binding is 98%, elimination half-life 12 hours, metabolism is in the liver, excretion is in the urine and feces. There are active metabolites. Adverse effects are as for beta blockers. Beta blockers with low lipid solubility. The pharmacokinetics of beta blockers with low lipid solubility includes poor absorption from the gut, reduced hepatic metabolism, and excretion is largely unchanged in the urine. Sotalol. Sotalol is used in the treatment of SVTs, especially atrial flutter and fibrillation, ventricular tachyarrhythmias, and ventricular ectopic beats. It is also used in the prophylaxis of paroxysmal supraventricular tachycardias following DC cardioversion. Sotalol is more effective at maintaining sinus rhythm following DC cardioversion for AF compared to other beta blockers. Ventricular rate is well controlled if the rhythm degenerates back into atrial fibrillation. Contraindications are as for beta blockers. The Committee on Safety of Medicines recommends that Sotalol should not be used for angina, hypertension, thyrotoxicosis, and perimyocardial infarction, period. The oral presentation is in tablets. The IV presentation is as a solution containing 40 mg in 4 ml. The oral dose is 80 to 160 mg BD. The IV dose is 20 to 120 mg IV over 10 minutes, repeated QDS as required. Mechanism of action. Sotalol is a water-soluble racemic non-selective beta blocker. It has no sympathomimetic effects. It is a racemic mixture. The D isomer confers class 3 activity, which is potassium channel blockade. The L isomer has both class 3 and beta blocking actions. Sotalol produces prolongation of the duration of action potential and increased effective refractory period in the heart. Onset of action is 5 to 10 minutes for ongoing VT via IV route. Pharmacokinetics. Lipid solubility is low. Absorption is 85% via the GI route. Peak plasma time occurs at 2.5 to 4 hours via the oral route. Bioavailability is 85%. Protein binding is 0%. Elimination half-life is 15 hours. Metabolism, nil. No active metabolites. 90% is excreted unchanged in the urine. Reduced dosage in renal failure. Adverse effects are as for beta blockers. Sotalol may cause prolonged QT interval and torsade de points, which occurs in less than 2% of those being treated for sustained VT or VF. Torsade de points are more common with higher doses, a prolonged QT interval, and electrolyte imbalance such as hypokalemia. Atenolol. It is used in the treatment of hypertension, angina pectoris, and ischemic heart disease. Off-label uses includes treatment of SVT, thyrotoxicosis, and alcohol withdrawal. Oral preparation is 25 to 100 mg tablets or 5 mg per ml syrup. IV preparation is a colorless solution containing 5 mg in 10 ml. The oral dose is 50 to 100 mg per day. IV dose is 2.5 mg slowly, repeated to a maximum of 10 mg, which may then be followed by an infusion. Atenolol blocks response to beta-adrenergic stimulation. Atenolol is cardioselective for beta-1 receptors at low doses, with little or no effect on beta-2 receptors. The onset time via the oral route is 3 hours for antihypertensive response and 5 minutes via the IV route. Duration of action is 12 to 24 hours via the oral route if there is normal renal function, and 12 hours via the IV route. Pharmacokinetics. Atenolol has low lipid solubility. GI absorption is 45%. Peak plasma time is 2 to 4 hours. Bioavailability is 45%. Protein binding is 5%. Elimination half-life is 7 hours. Actions appear to persist for longer than 7 hours. Metabolism. Atenolol undergoes little or no metabolism in the liver and is mostly excreted unchanged in the urine. Reduced dose in patients with renal impairment. There are no active metabolites. 50% is excreted in the feces and 50% excreted in the urine. Adverse effects are as for beta blockers. Celiprolol. This beta blocker is pending FDA approval for treatment of vascular Ehlers-Danlos syndrome. Celiprolol is a beta-1 selective blocker, which is a weak beta-2 agonist. It also has alpha-2 antagonist activity. It has direct vasodilator effects, which may be mediated by endothelial nitric oxide release. Celiprolol produces peripheral vasodilation in addition to its cardiac effects. It lowers blood pressure in patients with hypertension, but not in normotensive patients. It may have membrane stabilizing effects. Celiprolol provides clinical benefit for VEDS by promoting normal collagen synthesis in blood vessels and may shift pressure load away from vessels most prone to dissection and rupture. Pharmacokinetics. Celiprolol has low lipid solubility, oral absorption is 30%, bioavailability is 30 to 70%, protein binding is 25 to 30%, elimination half-life is 5 to 6 hours. Celiprolol is excreted unchanged via the kidneys. There are no active metabolites. Adverse effects are as for beta blockers. For other beta blockers not discussed here, kindly refer to specialist pharmacology textbooks. These are my references. Thank you.